Morning, everyone. Morning to everyone online as well, and everyone in the room. Welcome to the Friday academic meeting. It's a special one. It's special because it's obstetric medicine's turn to host the academic meeting, but it's also special because we're holding this in parallel with our Wits-Imperial obstetric medicine research collaboration meeting that we've been holding all week. I'm not going to take up a lot of your time because you hear from me all the time and you're tired of me. If the slides would move, I could show you what's happening. So a lot of this started, or this all started last year. I had the privilege of going to Queen Charlotte's and Chelsea Hospital in London and meeting the amazing team that are here today. Can I get you to say hello? So we have Dr. Fries, Ms. Primrose and Ms. D'Angel, as well as Professor Williamson, who I'll introduce properly later, who have kindly come out to join us this week. And what came from this is we applied for the African Research Universities Alliance Imperial Research Fund Global Seed Fund grant, which has funded this meeting this week. In part, our guests from the UK paid for themselves to come out and their accommodation and flights and everything, which we are very grateful that they've taken time out of their days and weeks and pockets to be with us. But so all week we've had a meeting. We had it at the Adler on Tuesday and Wednesday, and then we had it at Park Lane yesterday. And we had a wonderful research meeting here on Wednesday afternoon. And from that, we have identified 4 key areas that we do want to investigate. But enough about that. Today is International Women's Day. Everyone will recognize this woman. Do you recognize this woman? So you're in the building named after her. So that's a good start. So Charlotte Masheke, who obviously did a lot for women's rights in South Africa, and we are very grateful to have a hospital named after her. But I'm going to introduce someone now who's going to speak to us this morning, and that's Professor Catherine Williamson. Professor Williamson is Professor of Women's Health at Imperial College London. She is an obstetric physician based at Queen Charlotte's and Chelsea Hospital. And really, in addition to being an excellent obstetric physician, probably one of the, I'd say, founders of obstetric medicine early on, has done a lot for research in obstetric medicine, specifically research around liver disease in pregnancy. So I'm going to call up Professor Williamson to chat to us about liver disorders in pregnancy. This is working.
Thank you very much, Jarrod. It's a pleasure to be here. Thank you so much for hosting us. It's been a fantastic 2 days, or 3 days so far. And I'm very excited that we may develop some more collaborative projects going forwards between Imperial and Wits University, which will be amazing. So liver disorders of pregnancy. I'm going to start just signposting you to a new guideline. It's the European guideline from the European Association for the Study of Liver Disease. It's a clinical practice guideline for management of all liver disease in pregnancy. But I think it's really a very international guideline. I hope it would be very useful. Importantly, it is free for open access. So using the reference there, you can download this. It has a lot of references that are useful. The society, it's called EASL, were very selective about who could contribute. We had 7 international experts and also a wonderful Delphi panel. And all of the questions asked went through rounds of Delphi panel review. We did systematic reviews of the literature, 2 or 3 experts for each topic, which were then reviewed again by the Delphi panel. So I hope it will be a really useful reference for anyone looking after anyone with liver disease. It considers gestational liver disorders and pre-existing liver disorders. And I'll try to consider the most recent evidence-based guidance we can use for many of these through this talk. The guideline also has tables summarizing normal ranges for liver disease in pregnancy. Again, this can all be downloaded. There's a table summarizing radiological investigations and their safety. And that's important because sometimes we will have colleagues who are very worried about using some investigations. So it can be a useful reference for you talking to colleagues in multidisciplinary team meetings. There's also guidance on safety of specific drugs for both preconception, each trimester of pregnancy, and postpartum. Also for paternal exposure, delivery guidance, contraception, and a few downloadable flowcharts for management of gestational disorders. So to start thinking about diseases specific to pregnancy, if you think about somebody you see with de novo abnormal liver tests in pregnancy, these are the main conditions. Think about which would be more common. So for the UK, I can show you data from a study, it was 20 years ago now, in Swansea, and you can see common things are those that we all regularly see, particularly preeclampsia with hepatic impairment, HELLP syndrome, and in the UK, intrahepatic cholestasis of pregnancy, hyperemesis gravidarum in the first trimester, and acute fatty liver. I could not find any data for South Africa, but I did find a paper from Ethiopia. If anything, there's a bit more preeclampsia and HELLP syndrome, similar rates of hyperemesis and acute fatty liver, but cholestasis is less common. And this is consistent with what people have said to me when I've been here. I don't think you see it as commonly as we do in the UK. Raise your hands if you can't hear me, but hopefully everyone can still hear me very well. So I'm not going to say a lot about preeclampsia because I think you're all very experienced at managing preeclampsia, but I'll just touch on liver impairment in the condition. The new International Society for the Study of Hypertension in Pregnancy definition includes hepatic impairment alongside hypertension. And I think the important thing for women with either severe preeclampsia, either just with isolated elevated liver enzymes, or with what is called HELLP syndrome, which essentially to me, I think is very severe preeclampsia, which has multi-system involvement. But the important thing is they can have hepatic hematoma and sometimes rupture. And this is important because women become very sick and it can be fatal. So it's important to identify the symptoms summarized here: abdominal pain, epigastric pain, anemia, right shoulder tip pain, and have a high index of suspicion. So you will investigate and manage people quickly. In the guideline, we tried to summarize the evidence that help us to identify people that may be at risk of rupture. And there's very limited data, understandably, because these people deteriorate rapidly. But there was one study here, again quite old, where they recruited 34 women with HELLP syndrome and performed imaging. In this study, they performed CT plus sometimes MRI or ultrasound. And what they found was 50% of them had abnormalities, and almost all of them were due to a subcapsular hematoma. They also looked at the laboratory features that could be associated with having a hematoma, and the only one that was particularly useful was low platelets, a platelet count under 20. So in the guideline, we did recommend that an abdominal ultrasound should be performed in women with severe preeclampsia or HELLP syndrome if there are any symptoms suggestive of hepatic hematoma. And I think this is guidance that really can be generalized and hopefully will be useful here as well. So I'm going to move on to consider acute fatty liver now. In the UK, we still have approximately 1 death per year, maybe slightly less now. We had a prospective cohort study of 57 women a few years ago, case fatality rate just under 2%, high perinatal mortality. And they reported the associations in our population: multifetal pregnancy, which is consistent with the literature, low BMI, which was a new finding, and I suspect is because a number of these women have an underlying metabolic disorder, often fatty acid oxidation disorders, but they're of a variety of types, but others as well. And there were reports, particularly from one area of the States, of the mothers of children that have fatty acid oxidation disorders, much more commonly having acute fatty liver. And I think in that subgroup of cases, that is true, but I don't think it generalizes so much to our general populations where there isn't a family history of this, but it's worth thinking about, and we usually can screen the children. And it is, the model is quite elegant, considering a fetus that is homozygous for a disorder of fatty acid oxidation. So acyl carnitines will accumulate in the fetal compartment. It cannot excrete them, so they cross the placenta to the mother for excretion. But if the mother is an obligate heterozygote, she may not have sufficient hepatic capacity and therefore will develop acute fatty liver. So it's a very nice model. A number of us have screened a lot of pregnancies subsequent to this, and really certainly in our own population, in most cases, we do not identify fatty acid oxidation disorders in the children, but I think the model is very nice, and it probably will apply to other genomic susceptibilities. And this will be helpful for the subgroup where we find them for advising on future pregnancies. So how do we diagnose it? I think, as with many pregnancy conditions, acute fatty liver is really the endpoint of a number of pathologies. So we often talk about these criteria, the Swansea criteria that were published in a paper 20 years ago, and more than 6 were present in all cases with acute fatty liver. And that's also been found in subsequent papers. They're really features of acute hepatic impairment, many of them, but some are quite interesting. At the meeting yesterday, we talked about the fact that vomiting coming on de novo in the 3rd trimester is not hyperemesis, is not normal, and can be associated with acidosis for a number of reasons. It's also associated with acute hepatic impairment. Polydipsia, polyuria, if you ask people about this, it is quite common. And I think it's because when there's acute hepatic impairment, it's not possible to denature placental vasopressinase, and therefore features of DI develop. You'll see many of them. Hypoglycemia is often present, abnormal liver tests, renal impairment almost always present. So they're useful for distinguishing cases when you're thinking about a differential. Acidosis and metabolic acidosis and raised lactate are very, very commonly present as well. David Williams from University College London has some work about to come out showing in many women there's an absence of ketones, which again may relate to an underlying metabolic abnormality. But as I said before, these are really features associated with acute hepatic impairment. So look for encephalopathy, hypoglycemia, coagulopathy. You can correct the latter two before delivery, and think broadly about the differential. There are cases that present with what is thought to be acute fatty liver with drug toxicity, such as paracetamol, so good history. HSV can present with acute hepatic impairment and liver failure and can be fatal, and many women don't have vesicles with a new infection. So there's a broad differential that it's worth thinking about. Once you've made a diagnosis, you do want to try to predict who is likely to deteriorate. And I think the most useful data we have are from this study from the King's Liver Unit, where they retrospectively looked at the people that had come to their liver intensive care either with acute fatty liver or hypertension-related disease, really severe HELLP syndrome. And they found the best predictors were serum lactate and the presence of encephalopathy. So I would say always check a lactate in these cases, and you can see the area under the receiver office curve is really quite impressive. So simple, straightforward things to check. And of course, as we all know, once you diagnose somebody, you want to stabilize them, deliver quickly. They need multidisciplinary team approaches and need to be in either a high dependency or intensive care setting. I mentioned N-acetylcysteine here. We tend to give it. I don't know, but I assume it's available here to give to people. There is no evidence for it, but it is very unlikely to do any harm. It may be helpful. Once you've stabilized and delivered, most women improve pretty promptly. They might get worse for a couple of days, but then get better. In my experience, recurrence is rare. I think the occasional case where you find a Mendelian disorder, it's easy to predict. But for many, I think we just give them much more intense input in a subsequent pregnancy. There's a higher rate of preeclampsia, so we often give aspirin as well. And usually women do well. And if they do develop any features, I think we moving quickly and deliver them and stabilize them. There are some non-randomized trials that show some benefit with plasma exchange, but it hasn't really been studied in larger trials. So to come on to think about intrahepatic cholestasis of pregnancy, I'm not going to say too much about ICP because I know you have less of it here, but I'm sure you must have some cases, and I can't resist saying a bit because we've done quite a bit of research on it. In the UK, it affects a bit less than 1% of pregnant women. It's commoner in women of South Asian ancestry and even commoner in those from the Andean regions of Latin America. The prevalence in African countries, I can't find any reports, but I just show at the bottom here a graph from a paper where we looked at normal ranges of bile acids in the blood in women of different ancestries. This is a South London population. And you can see women of European ancestry here really seem to cluster around what we call the normal ranges. Here are women of South Asian ancestry. Maybe they have a tendency to have slightly higher bile acids. And here are women of African ancestry in London. Now these are women who were thought to have uncomplicated pregnancies. So I think it's possible maybe women of African ancestry are less aware of itch and could be having higher bile acid. So it's worth maybe being aware of that in women where you have some suspicion. If it's possible to get a total bile acid assay, it would be worth maybe sometimes having a look. And maybe in somebody who has an unexplained stillbirth with a little bit of hepatic impairment. So we and others have done quite a bit of work now trying to think which biochemical markers are most useful to think about prognosis. We did a big individual participant data meta-analysis. It was an international collaboration, and I'm grateful to all the collaborators. And we showed that really the only biochemical marker of value to consider prediction of stillbirth is serum bile acid concentrations. If I just show you this graphically, this shows all the cases in this study. It was just under 5,000. The blue bar represents the number of cases. And this is the incremental value of the mother's bile acids in 20s. So up to 19, up to 39, 59, and so on. The red bars are the stillbirth rate. And you can see when the mother's bile acids go over 100, that goes up markedly. In the right-hand graph, this is the stillbirth rate according to number of fetuses in utero at gestations 24, 26, 28 weeks, and so on. The green bar is those with bile acids under 40 micromoles per litre. The purple bar here is from 40 to 99. So this bar, 100 and above, is where the stillbirth rate is markedly increased. And you can see it particularly goes up somewhere between 35 and 36 weeks of gestation. We did the same thing for preterm birth. It's a more busy graph, but essentially the same message. The red bar is all preterm birth. And then here we have purple bars that represent iatrogenic or physician decision preterm birth, and green bars, spontaneous preterm birth. And you can see they all effectively go up as the mother's bile acids are higher, but spontaneous preterm birth does. And if you look at the right-hand graph, it's the same as the one before. Preterm birth rate according to number of fetuses in utero, green bile acids under 40 micromoles per litre, purple 40 to 99, where there is a significant increase, but when they're over 100, even more. So I'm pleased that these findings are now reflected in most of the international guidelines. If a woman has bile acids over 40, you know she is at significantly increased risk of spontaneous preterm birth. If they're over 100, also at risk of stillbirth. And I would say after about 34 weeks, they should be rechecked regularly if they haven't been high, so you don't miss someone whose bile acids are keeping on going. The other question people often ask, should we check bile acids when somebody's fasting or not fasting? The simple answer is not fasting, unlike outside pregnancy, which hepatologists will always say outside pregnancy, check them fasting because they go up after we eat. But in pregnancy, we want to know about the peaks. So this graph here shows a blue line representing bile acids in those whose bile acids went over 40. Red is ICP in those who didn't, and black is uncomplicated pregnancy. These are women who had samples taken at different times of the day and were on a standardized diet. So they took a standardized meal the night before. Came in fasting, these fasting samples, and then through the day after standardized meals, had samples taken. And the important message here, here's the threshold of 40. If you only measure fasting bile acids, this blue group, you'll miss 90% of women whose bile acids go above the threshold. So you won't predict those at risk of the adverse outcomes. The other question people ask for cholestasis is what drugs? Ursodeoxycholic acid is the main one that has been used previously. There was a big trial in the UK. There have been a number of other smaller trials in other places. The UK study randomized to ursodeoxycholic acid or placebo to see if there was a change in a composite outcome of fetal death, neonatal death up to 7 days, preterm birth, and neonatal unit admission for at least 4 hours. The groups were very well matched at baseline, but I'm just going to draw your attention to the bile acids at baseline. Only a quarter of them had bile acids over 40, which, as I've just told you, is the group that were at risk. So this is a real world population, but maybe not all at risk of the adverse outcome. And the results were that the drug did not change the rates of the adverse outcome. It did show there were over 600 women in this study. Itch improved slightly, and itch can be a big problem for some of these women. Transaminases improved, and the drug is known to improve transaminase concentrations. But we went on to do another individual participant data meta-analysis to think about bile acids under 40, bile acids over 40, does the drug work? And I hope this picture will speak 1,000 words, and that these are the women with bile acids under 40. No difference between the blue line and the dashed red line, and the dashed red line being URSO-treated women. So no increase in preterm birth and no difference. But in those with bile acids over 40, a marked increase in preterm. This is spontaneous preterm birth in singletons. In those not treated with UDCA, which was significantly reduced with the drug. So I think there is an argument, if you identify somebody, bile acids over 40, I would give ursodeoxycholic acid because you will be reducing the rate of spontaneous preterm birth. But it's not good for itch. If you have women with bad itch and you're still worried, the other drug that you could consider is rifampicin. It's used for itch in cholestatic disease outside pregnancy and is quite effective. This is a retrospective study where we just looked at women that didn't respond to urso, treated them also with rifampicin. They act by different mechanisms, we can give them together. And about 50% of them had an improvement in bile acids and also an improvement in itch as far as we could assess it retrospectively. There's a trial now being run by Bill Haig in Adelaide. It's an international trial evaluating the role of rifampicin in ICP, and I think in about a year we'll know. So it could be the other drug that's widely available and we could use. Bear in mind, I'm sure you will know, but we do have to remember in pregnancy, some women have an idiosyncratic drug reaction and their transaminases will get worse. I've seen this, they go back to what I would think would be baseline if you stop the drug. So I watch for it closely, but it doesn't stop me using the drug because most people are okay on it and about 50% will respond. But this trial will tell us its true role. I want to come on to talk about hyperemesis gravidarum. Now, most of the people I've been speaking to, and I think I've been speaking to people here who are obstetric physicians or obstetricians who may not see the early pregnancy people so much. I know some of you don't see a lot of hyperemesis. We do see quite a lot of it in the UK. If anyone wants to talk more about this, I'd be delighted to think about collaborating and doing more work on this. It's essentially severe nausea and vomiting in pregnancy, and the international consensus definition that was published a few years ago describes it as occurring under 16 weeks of gestation. Women have nausea and vomiting, one of which is severe. Remember that severe nausea is debilitating. People can be bedbound with it. An inability to eat or drink normally, and symptoms that strongly affect daily activities. And not all women just have it in the first trimester. Certainly in our country, 1 in 5 with true severe hyperemesis have it throughout gestation. So starvation affects most systems of the body. I'll briefly talk through this slide and highlight points that I think are important. If you have a woman with hyperemesis, keep a close eye on her electrolytes. Women can develop quite marked hypokalemia and hyponatremia. I used to assess the maternal deaths in the UK, the Embrace report. I would say more than once every triennial, essentially once a year, I think there's a woman who dies who has hyperemesis. It might not be reported as a hyperemesis death, but if you look closely, there were women with potassiums that were very low and they suddenly died overnight. And certainly you have to be alert to that. So watch the potassiums, think about replacing them, also sodiums, and remember careful replacement of electrolytes. Don't give dextrose, normal saline or Hartmann's to carefully replace electrolytes. Women will be dehydrated, so increased risk of venous thromboembolism. They do have liver enzyme disturbance, and it's always considered in liver guidelines, and there's a downloadable management flowchart in the European guideline. But I think they have elevated liver enzymes because they're starving. And if you treat the hyperemesis, the vast majority get better. Often GI symptoms of reflux, esophagitis, and they respond well to a PPI. Biochemical thyrotoxicosis is talked about a lot, but it does resolve again with treatment. Very, very rarely do people have true thyrotoxicosis, and it can be diagnosed very easily clinically by taking a history and doing an examination. Wernicke's is important. If people are vomiting and can't get nutrients in, they can develop B vitamin deficiency very quickly, particularly thiamine. So if you are seeing somebody who's not managing to get food in, replace thiamine or give them Pabrinex. It's so easy to do. And every year or two, there's a report of a case that develops Wernicke. We had one in the UK just a few months ago. So it's really worth being alert to that. And it's not just a disease of the mother. There are also consequences for the fetus. And I think this is an important message to give to women and to their relatives. We're treating them because it's good for the mother and the child. Fetuses are small for gestational age. There are regularly reports of intracranial hemorrhage. I think that's vitamin K deficiency. And emerging quite convincing data now that the children of women with HG have about a 3-fold increased risk of neurocognitive disorders, particularly autism spectrum disorder, and a bit like the children of women in famines, increased risk of metabolic disease later in life. So alongside the physical effects, this condition does have quite marked effects on maternal mental health. We analysed a survey in the UK. This was distributed by the BBC over a 3-week period, and over 5,000 women with HG responded. And some of the data were quite striking. Almost 5% terminated a subsequent pregnancy as a wanted pregnancy because they couldn't bear to go through HG again. Just under 7% experienced regular suicidal ideation. Last year, there was a woman in the UK who committed suicide with HG, where there was a lot of media publicity around it. And hopefully this will focus people a bit more on the mental health consequences. Those with these adverse outcomes, they were more likely to terminate a pregnancy or have suicidal ideation, not surprisingly if they had more severe sickness, poorer functional status, unable to get up, look after other children, go to work, earn money. And also it was associated with a perception of poor quality of care in primary and secondary care. In this survey, people had the option of writing comments. Now, those of you who've done this type of research before, you usually don't get many comments. In this survey, we had over 5,000 comments, and both Melanie and I, who read them and analysed them, they were very moving. And I'll just give you a feel for some of the comments that people made. So here is the number of people that made comments along the lines of this, and these are just examples. So my partner recalls being able to see my bones protruding through my skin. In terms of termination, I could not take it anymore and asked for a termination. It was that, or I think I would have taken my own life. I had nothing left. Suicide, I felt scared alone, attempted suicide when it felt like the only way out. A lot of people felt they weren't taken seriously by those in both primary and secondary care, and family didn't understand. So my family accused me of hurting my baby because I was on constant medication. So you can read faster than I can read the comments out to you, but they were quite astounding, the extent to which this condition affects people. So ask them about their mental health. Guidelines, we have very good guidelines. This is the new Royal College of ONG Green Top guideline. I think it is absolutely fantastic. And it even has one-page summaries for people in different specialties. So for emergency care, early gynecology, early pregnancy units, and so on. It's evidence-based and very sensible. This is from the previous guideline, first line, second line, third line treatments, and you can start with these and then you can time them at different times of the day. I think most of these drugs will be available here, or certainly there's enough from each group that they can be used. And the new thing in the guideline is Zomvia. I don't know if you have Zomvia here. Zomvia is doxylamine, which you probably do have. Could you raise your hand if you have doxylamine?
So we have doxylamine as an over-the-counter sleeping pill, Somnol.
Okay.
Which I use.
Well, yes, you could. The good thing about it is this is an expensive preparation. It's just doxylamine and vitamin B6. So that's very pragmatic. Or you could recommend people can buy it for themselves. I don't think it's good for it's good for really severe disease, but it doesn't always resolve really severe disease. But moderate disease, it's pretty good for. And also, it can be this data to show it works preemptively. So if somebody's had the condition before, if you see them and advise them, they can start it at around about the stage of pregnancy. Their symptoms started when they think it's just starting. And when that was done, it reduced the severity of HG, and more women had the condition resolved before they gave birth. So it's worth being aware of that. The guideline also emphasises the safety of ondansetron, and I think that's important because there have been some papers that suggested that it's associated firstly with cardiac malformations, but the data are conflicting. There were no controls, and so there could have been confounders. And similarly with the data relating to orofacial clefts, the data are conflicting, and if there's an association, it's small. And I'll show you this quite useful infographic that was made by the Irish Medicines and Pregnancy Service. Clefting, background risk, 11 per 10,000. If the paper on Dansatron is true, given the confounds, yes, there are only 3 more cases per 10,000. And weigh that against all the complications I told you about of this condition. And I hope this is useful to counsel people. Other things in the guideline, previously some guidelines had said only take metoclopramide for 5 days. Of course, a woman with an ongoing condition in pregnancy can take drugs for longer. So that, and also removing ketones. Ketones are often used to decide whether to admit people. But as Charlie Fries said in her talk yesterday, that some of you will have heard, ketones are made when we break down fats for energy in pregnancy. They're not a marker of dehydration. And if a woman eats a biscuit, they might get a bit better. That might be the only thing she's eaten. So don't use them as your gatekeeper for admission. Look at the whole woman. So I'm going to move on now to conditions incidental to pregnancy. And a condition that I think is really important, and I'm worried that we might all see more of, is cirrhosis. The data in this slide come from a big Canadian study where they looked at hospital records to evaluate the number of women with cirrhosis, what the underlying etiology was in their country, complications. Now, they saw rising rates of childbirth, but look at the etiology in North America. Almost 3/4 of women have what was called NAFLD or MASLD, steatotic liver disease causing cirrhosis. I'm worried about this because I think this could be of relevance to us all. In terms of adverse outcomes in pregnancy, there's an association with cholestasis, induction preterm birth, peripheral infection, large for gestational age infants, probably because now they have a lot of people with MASLD, and neonatal respiratory distress. Death and transplant are much lower than was reported in older studies, which is fantastic. But decompensation still occurs in between 1% and 2%, variceal hemorrhage being the major cause, but there are others as well. So those are the Canadian data. I think they're encouraging. So death rates are much lower than in older studies, and I hope that's because people are being ascertained and actively managed. Most studies have shown that if women are screened for varices and have banding either pre-pregnancy or screened in the second trimester and have treatment, they're much less likely to have GI hemorrhage, and that's the main cause of death. So I think a really big message is that there should be screening for varices. Think about splenic artery aneurysms. Anyone who's seen it knows it's awful, and they can be treated and they can be prevented. So just think, your women with cirrhosis are more at risk of them, and the thresholds the vascular surgeons use for intervention, or the interventional radiologists, are lower in pregnant women. We've just done a study in the UK. It was a prospective study with the UCOS system, which is where there's all consultant-led obstetric units report data. We identified 52 women in this study. And I think the most interesting thing for us is our etiology is different to what was reported in North America. So steatotic liver disease is a very small cause of cirrhosis in this series, but these are of course only those that have been ascertained. Compare it to the American data. So we still have a lot of autoimmune hepatitis, underlying cholestatic disease, viral hepatitis causing our cirrhosis. But I think we, and likely you, are going to see more and more people with steatotic disease, and we should think about ways to screen for them, because I think it's important to identify and think who would be at high risk. In terms of adverse outcomes, these are our data that are being submitted for publication now. So the same as the Canadians, more cholestasis. We have higher rates of maternal intensive care admission and cesareans, preterm birth and low birth weight, and higher perinatal mortality. And a lot of the neonatal deaths related to preterm birth. Can we predict those more likely to have adverse outcomes? Well, in terms of simple prediction, we looked at the ALBI score, which is albumin and bilirubin, and the worst score when checked in pregnancy, because we still see too many women presenting in pregnancy, and I'm sure you'll be in the same position. But this is in pregnancy. We can predict those more likely to have adverse outcomes, and then maybe we can triage them to have more intensive care. And this is consistent with other studies that have shown the MELD and UKELD, so these use creatinine, bilirubin, INR, and the UKELD uses sodium, when used pre-pregnancy, also predict those with adverse outcomes. So there are tests we can do simply to think who's at highest risk with cirrhosis. So in terms of cirrhosis, we should all try to see these women for pre-pregnancy counselling. I think it's very disappointing when we looked at our data that under 50% of them had pre-pregnancy counselling, because nowadays they have much higher fertility rates, I think because the underlying etiology is changing. And then we manage them in a high-risk team, and do an endoscopy to look for varices, because you can prevent that woman from having a devastating hemorrhage. And we give beta blockers, usually carvedilol, but I think any beta blocker is better than none, to offset the impact of varices in women with cirrhosis. So MASLD, or NAFLD as it was caused, is going to be increasingly common. This is American data, US data, again using health records, where they showed that pregnancies with steatotic liver disease have tripled from 2007 to 2015. They have more GDM. And when they compared these women to those that don't have it, or don't have known liver disease, higher hypertensive disease, higher preterm birth, higher PPH. So as I said, it would be good if we could identify them. I'm quite frustrated that in my hospital at the moment, we don't have a FibroScan, but I was told yesterday that you do. So if somebody wants a project, I think this would be an amazing project to see what the prevalence is. So other conditions incidental to pregnancy, autoimmune hepatitis, it occurs in women of childbearing age. Some women even present in pregnancy, but again, the data show that less than half, I think this was Sweden, this study, have pre-pregnancy counselling. It's really important, because what we don't want is well-meaning caregivers or women stopping their immunosuppressive therapy, because they're far more likely to have adverse outcomes. And this is just to show you what the drug table is like in the guideline. It's just like the rheumatology guidance. So we have compatible periconception, first trimester, second, third, breastfeeding, paternal, and here, tacrolimus, safe, cyclosporin, safe. And many of these women are on azathioprine, which is also safe and is elsewhere in that table. And of course, think about whether they have cirrhosis or not, varices or not, all the same messages as for cirrhosis. And remember, one autoimmune disorder means a woman's more likely to have another. So think broadly in terms of other endocrine immune disorders and other immune disorders. So viral hepatitis, I'm not going to say a great deal, because most hepatitides have the same course in pregnancy as outside pregnancy, but I'll just mention a few important points, and they're all covered in the guideline. So hepatitis C, as you know, is a blood-borne virus. So people can contract it for many, many reasons, and some will do so in childhood and not know they have it. And pregnancy is a time when they may present with hepatic impairment. They're more likely to get cholestasis if they have hepatitis C and don't know they have it. In terms of guidelines, I think the Society for MFM guideline is very good. Recommends against cesarean delivery solely for the indication of hepatitis C, because it doesn't affect mother-to-child transmission. Ideally, try to not use internal fetal monitoring for long rupture of membranes, particularly if a woman has a high viral load. If there's an undetectable viral load, the concern is much less. And do not discourage breastfeeding because of a diagnosis of hepatitis C, because there's no evidence that it has an impact. The other thing, our European guidelines say all of these things, but we also recommend testing women in pregnancy, because the economic benefit of testing, certainly in our country and in Europe, makes sense, because you refer people to post-pregnancy clinics, treat them, and you'll treat the mother and eradicate it if a child's affected the same. Hepatitis B, I know you will see a lot of hepatitis B here. I've basically summarized some of the main comments from the guideline, which are all recent evidence-based. So antepartum immunoglobulin, no evidence for that. Antiviral prophylaxis is recommended if the maternal HBV DNA viral load is above the thresholds given here. And in those with cirrhosis or fibrosis should be continued. Breastfeeding, if they're on therapy, should be encouraged, and there's good data to support that. Amniocentesis, be aware if they have a higher viral load, careful counselling for risk versus benefits. And HBS antigen can be of value and as a predictor of the HBV DNA level. Hepatitis E is one condition where the prognosis in pregnancy is worse than if somebody has this outside pregnancy. And there's emerging data where if there's evidence of fetal infection, it's thought that that might exacerbate maternal disease, almost as an example of mirror syndrome. We have also recommended that if somebody is very sick with encephalopathy and acute hepatic failure, therapeutic termination of pregnancy could be considered because it could improve maternal prognosis. So the final thing I want to mention is drug-induced liver injury. It doesn't come up in that figure I showed you earlier, thinking about your new woman presenting in pregnancy, because it's not a gestational disorder, but it is common. Take a good history, because women might be taking therapies that you don't know they're taking. And also a lot of commonly used drugs cause liver injury. And it can be divided into hepatocellular or cholestatic. And it's worth thinking about that, because you might manage them differently and think about what drugs you can stop or switch them to. So I'll stop there. Essentially, this is some of the main points of the talk in one slide, but I think my final slide, I just want to acknowledge a few people. This is the people that wrote the European guideline. This is Melanie Nana, who was the trainee rep on the guideline and also did the cirrhosis work. And Alice, Caroline and Jenny did a lot of the cholestasis work I've told you about. But the most important thing here, I think, is the co-authors on 2 of our recent papers. And I just pulled that out because what really matters is if you want to do research that's of relevance to a lot of pregnancy disorders, I think collaboration is essential. And it's something we've talked a lot about over the last few days. And if anyone wants to collaborate and work together, please be in touch in terms of these conditions. I'd be delighted. Thank you.